All right, hello everyone. About to get started now. Welcome to our webinar on birth suppression. It is hosted by Dr. Navita Kaushal. She has been with us at CortiCare for 4 years. She has been in the field for 10 years. She also brings 14 years of teaching experience of anatomy and physiology, as well as 10 years of experience in research on the effect of sleep deprivation and hypoxia on the progression of neurodegenerative disorders. So we are very lucky to have her. She always puts on very good and informative webinars. And without further ado, I will pass it on over to her. You are muted, Navita.
Good evening, everyone. It's 6 p.m. here in Pennsylvania. It's too dark, feels like midnight already, right? Okay. So today we're going to talk about birth suppression, if it is a friend or a foe. So in chat, if you mention, are you in EEG or intraoperative monitoring field? So I am trying to cover birth suppression in both the arenas. And any questions are welcome during the presentation. Just put it in chat and Brad will take over. And we can have the QA session in the end too. Here is an outline on this webinar. We're going to talk about what is birth suppression and what's the reason, like what causes it, this particular pattern. What are the different categories of birth suppression and how to describe this particular pattern? Being an EEG tech, we need to know to describe our patterns. What are the clinical conditions that produce birth suppression? And what are we looking at when we are inducing birth suppression, and why are we inducing it? And we're going to talk a little bit about intraoperative birth suppression and post-operative delirium. Okay, so in anesthetized cats in 1936 and in 1949 in dogs, that's where this pattern was seen many years ago. So this particular pattern, if we want to put words to the looks, it is an alternative epochs of isoelectricity and active oscillations. And this pattern is characterized by high voltage, high amplitude bursts, which are more than 20 microvolts, go as high as 120, 140 microvolts, alternated by periods of very low activity or complete suppression. And the voltage of that activity is about 10 or less microvolts. It has to be there at least for 1 second. I know it's a little confusing. We will talk in detail about it. Birth suppression can be physiological. During the early developmental years of the neonate's life, we do see birth suppression, but that is not to be categorized as something abnormal pattern. Birth suppression can be pathological too, due to cardiac arrest, hypothermia, coma, and even early infantile epileptic encephalopathy. In our professional life, we see that there are lots of sedatives, lots of anesthetics that can induce birth suppression. In certain situations, this pattern is considered friendly. It's considered desirable. We want to see that so that the sick brain can heal. However, in certain conditions, certain clinical conditions, this pattern is considered very dangerous, very harmful, and there is no recovery from that, and even during surgery also. So we all know this pattern is abnormal. Whether it is needed or not needed, it is an abnormal pattern in EEG. There is an imbalance of neural activity and available energy in the neurons in the brain. There is cortical hyperactivity. So the bursts that we are seeing, there is cortical hyperactivity. There are changes at the cellular level. There are changes in the electrolytes. There are changes in the ions, the ATP. You name it. There is a lot happening either due to sedation or due to the pathology. The bursts that we see, that is the hyperexcitability because there is decrease in inhibition of the neuronal activity. So it's a game of excitability and inhibition, right? So the bursts are the hyperexcitability of the neurons, and the suppression, as it says suppression, it is absence of synaptic activity. So there is high concentration of calcium ions. So if we want to talk about the cellular level, all the ions that are responsible, sodium, potassium pump the calcium ions to excite the neurons and to calm the neurons, inhibit the neurons, and things like that. We're not going to go in detail of that. So the burst that we see, there is increased concentration of calcium ions around the neurons. That's when we see bursts. And when the intracellular calcium exhausts, we see a suppression pattern. So during the suppression pattern, that calcium rebuilds itself, and we see another burst. So it's like a very periodically, very rhythmic pattern that we see. Burst, and suppression. The DBG burst suppression ratio is 4:1. That translates to 80% of suppression. And 80 is a magic number in the EEG world, right? Whether the patient is having uncontrollable seizures, clinical or subclinical, 80% suppression is kind of expected and demanded, and the way the meds are titrated is to achieve 80% suppression. That is the deepest ratio, deepest suppression. Let's talk about the categories. Do not get confused with something else that we're going to talk after this. When we say there is burst suppression is absent, so that means we're talking in a 2-minute epoch. 2-minute epoch, if you are seeing less than 24% of signal attenuation or suppression, we are going to call it that it's not there. There is incomplete burst suppression. I don't know if this classification is being used so much in the clinical world, but this is from the ACNS terminology. When you see more than 20, but less than 50% suppression in a 2-minute epoch, that means from 24 to 59 seconds. So we are taking our range is 2-minute epoch. So we're going to call it an incomplete burst suppression. Complete burst suppression is when you have more than 50% of 2-minute epoch is suppressed. Now let's translate into some of these pictures here. If you see, this pattern is continuous, so less than 1% of suppression is there. So this pattern is a continuous pattern seen in ICU. And then we have a near continuous pattern. In this pattern, there is 1 to 9% of suppression. We're not going to talk attenuation. I'm going to show you a slide, the difference between suppression and attenuation, but we're going to focus on term suppression here. Again, the ACNS terminology describes this 1 to 9% of the record being suppressed. And here is our discontinuous pattern. So we are still not calling these patterns, this much of suppression as burst suppression. So the background here is discontinuous. This is of utmost importance when you are reporting a pattern in ICU patients, when the patient is supposed to go to X percentage of suppression. So this is of utmost importance, especially for the monitoring text. When you're reporting every hour, what is the suppression, what's the ratio, what's the percentage? So in a discontinuous pattern, we are still seeing more cortical activity, almost 51%. If we are seeing it, the pattern is still not burst suppressed. So 10 to 49% of suppression. That means so you still have 51% of activity going on. So what exactly is burst suppression? When you have more than 50% of suppression, 50 or more suppression in your EEG, you're going to call it burst suppression. So here you will see bursts are longer than half a second. They have more than 3 phases. And in between the burst, the activity, the cortical activity is suppressed, and the voltage there is less than 10 microvolts. So just to compare this particular picture, this particular epoch of burst suppression with this is burst attenuation. What you are seeing in between the high voltage burst is attenuated voltage, attenuated background, which is more than 10 microvolts. So we are not going to call it burst suppression. We're going to go back. So here there is a suppression of activity, and here we have attenuation of the background voltage, background frequencies. Okay. When I was in EG school, I always was thinking like, okay, transit discontinue looks like burst suppression. Why aren't we labeling it as burst suppression? Transit discontinue is not burst suppression. I mean, with my students also, like I have seen, they will be so confused and they want to market burst suppression. Well, it is not. So on the left here, we have an HIA baby, and on the right, we have a premature neonate, 28-week gestational age. So the transit discontinue is a reactive pattern, and it changes with age. However, the burst suppression is an abnormal, non-reactive pattern. And these bursts can be of anything. They can be epileptic. They can, anyway, in HIA, they are epileptic. So these bursts are of variable morphology, variable duration, but the suppression is longer. And this pattern is non-reactive. Alrighty, discharges. What is the difference between burst suppression and discharges? We say the patient has GPDs versus patient has burst suppression. So discharges are not bursts. The key is the duration of the activity. Your burst suppression is bound to occur with activity and no activity. So you have bursts, you have suppression, but the discharges, it's not that they'll not happen on a suppressed background. They can, but they can also appear with background frequencies. There is some voltage of those frequencies. We need to describe them. We need to recognize, identify, and then describe them, because reporting a patient having GPDs versus a patient having burst suppression are two different giants, basically. Your discharges can be consistent, fluctuating. That's how you describe them. They can be evolving or they can be static. So here is an example. We see that the background is suppressed in all these three pictures. Background is suppressed. On the left top green one, we have 1.5 hertz GPDs, and background is suppressed. In the bottom left, we have fluctuating GPDs. The morphology of these GPDs is different what we are seeing up there. Nonetheless, they are GPDs. They are not as consistent as we are seeing in the left top. At the bottom, we have fluctuating GPDs with variable suppression of the background. However, on this right side, the single image which is standing here, this is burst suppression. So you have bursts. A burst has to be longer than half a second. That's the key number here. Longer than half a second, the pattern will be categorized as burst. And this qualifies for that. Of course, we have these GPDs in the last second of the image. So what does the ACNS guidelines tell us? So we'll start with the burst. The last image here, the last picture on this side, it's burst. Longer than half a second and having more than 4 phases. The burst lasts up to 30 seconds. So from 5 seconds to 30 seconds. So if you remember in the beginning, we talked about different categories of burst suppression, right? So this 30 seconds fall in that category. After 30 seconds, you have to start considering if your background is discontinuous. What about discharges? Discharges are less than half a second. Think spikes, think sharps, right? 70 milliseconds, 200 milliseconds. So that is what, quarter of a second, right? So your spikes and your sharps are discharges. So think that duration, I think that is chiseled since our EG school, that duration is chiseled in our head, right? So your discharges are less than half a second. Now, do discharges appear longer than half a second? Then you have to start thinking about the phases. No matter how many phases a discharge has, as long as it's less than half a second, it is a discharge. But let's say you see a pattern which is longer than half a second, and then you focus on the phase. How many phases it has? A triphasic can be longer. If you have blunted, broad-based triphasics, they will not be a burst. They will be a discharge, like GPDs of triphasic morphology, and then you give the frequency. So 3 phases, that's where the cutoff is. So that means triphasic. What this terminology tells us is triphasics are discharges. So this is the biggest difference. So when you describe a pattern with GPDs or describe a pattern with bursts, keep these numbers in mind. All right, let's say we have a patient with burst suppression. How are we describing? What are the terms we are using to describe the burst suppression? First thing that you would do is the percentage of suppression. Some people described as percentage of burst, percentage of suppression, but the ACNS guidelines tell us to describe what is the percentage of suppression. That's what we report to. 80% suppressed. We want 90% suppressed. So if there is only 1% of suppression in an epoch, it's not suppressed, right? It is a continuous background. So if it is 99% suppressed, it is again not burst suppression. It is a complete suppression of the background. Now, an example down here, this is again picture picked up from the ACNS terminology. So you have 8 seconds of suppression and 2 seconds of epoch. So it means your background, your EEG, is 80% suppressed. So take a couple of epochs in consideration. Just see if there is a range. Just see if it is a consistent suppression, 80%, 85%, maybe 90%, 75 to 90%. Couple of epochs, you can always provide it as a range. If not an absolute percentage value, at least you can provide a range.
And Navita, we have a question about why you called one of the patterns fluctuating.
Okay, so I'm going to go back. The fluctuating means it is not consistent. They are periodic, but they have this gap in between. Unlike the top green, where you have a persistent, consistent time between the discharges, right? At the bottom one, they are not appearing as periodic as they are on the top, but nonetheless, they are still periodic. We love to call quasi-periodic. So the newer term for quasi-periodic is fluctuating. They are fluctuating in their duration, in their frequency, and even the suppression is variable. So that's a newer terminology. Okay. The next thing is localization. So if you have read the paper on terminology, it talks about main term 1, main term 2, right? Same way, we are going to describe our bursts. Just describing suppression is not enough. Now we want to talk about the burst, because the morphology of the burst tells a different story altogether. The burst can be spikes and sharps. That means epileptic. The burst can be delta theta. So you have to tell your story based on their appearance, their looks, right? And where they are present, which part of the brain they are coming from, right? So we talk about the localization of the bursts. Are they generalized? The bursts, are they lateralized? You can have unihemispheric burst suppression. You can have bilateral independent bursts. One brain behaving in 2 or 3 different manners, right? Unilateral independent. So maybe the frontal lobe has its own burst and the temporal and parietal have their own bursts. So that will become your unilateral independent bursts. Your bursts can be multifocal. Especially babies have multifocal seizures, multifocal bursts they can have. Now, what is a typical duration of bursts and the interburst interval? Before we talked about the percentage. Now we are talking in terms of duration. So you give that in seconds, and if it is longer than that, you give the duration in minutes. All right, the morphology, the sharpness. Let's talk about the sharpness. If your burst, I'm going to talk from reverse here. Number 4, your burst can be blunted. Like some of the triphasics are blunted, some of the triphasics are very sharp, right? So your bursts can be blunted. That means they have a smooth sinusoidal kind of morphology as seen at the bottom picture here. Spikes and sharps, again, the 70 millisecond rule and the 70 to 200 milliseconds. So if your bursts are sharps, they have the duration of 70 to 200 milliseconds. If they are spikes or they are spiky, it means the duration is, you're looking for duration less than 70 milliseconds. Okay, now there is one more category, sharply contoured. So these bursts, these kind of patterns, they do not fall into spike or sharp. They are too wide to be called sharp, right? They are above 200 milliseconds. And then we call them sharply contoured. So the sharpness of the burst, when describing the burst suppression, so when you're describing your burst, you talk in terms of whether they are spiky, they are sharp, sharply contoured, or they are blunted. Not all bursts are epileptic, but we do have epileptic bursts and highly epileptiform bursts. The ACNS guidelines specifically talks about us describing our bursts if the highly epileptiform bursts are present or absent. Like I said in the beginning, burst suppression is an abnormal pattern. The bursts can be seizure fragments, right? Maybe they are less than 10 seconds, so that's the target. Status epilepticus, we want to recover the brain. We want to have the brain calm down and heal. So our bursts become smaller. The activity of the neurons becomes smaller because of the suppression. So that means the bursts can be epileptic. Now, ACNS guidelines talk about highly epileptiform bursts. So I'm going to talk how that is different. Epileptiform, there are also spikes and sharps. Highly epileptiform are also spikes and sharps and polyspikes. Okay, so in your burst, if there are 2 or more epileptiform discharges are present, and you see them in more than 50% of your bursts, that would be considered as highly epileptiform burst. Again, 2 or more epileptiform discharges. It means if you see only one spike or one sharp in your burst, you are not labeling it as highly epileptiform. That is epileptic discharges. But for a burst to be called highly epileptic, there should be 2 or more epileptiform discharges in one burst, and you should see that in more than 50% of the bursts. And these discharges, their frequency is 1 hertz or more in one burst. Okay, so here is an example. So if we look at this, there is burst 2. So they're showing 3 bursts here. Burst, first and second burst, it shows that there are 2 epileptiform discharges here. The third one, there is only 1 sharp wave. So there are 2 sharps in the first one, a sharp and a spike in the second one, and only 1 sharp wave in the third one. That means the first 2 are considered highly epileptiform. However, the third one is not considered highly epileptiform. These are epileptic discharges. These are interictal discharges, but they are not categorized as highly epileptiform. And this is occurring in more than 50% of the bursts, and the frequency is more than 1 hertz. Okay, and then there is one more. This is another pattern to be called highly epileptic. Now, if you are seeing no rhythmicity, again, when I said delta theta kind of a thing, right? So if there is a burst without any rhythmic, potentially ictal appearing pattern, so this is not rhythmic and this is not potentially ictal appearing pattern, we're not going to call it highly epileptiform. Let's look at number 1 and number 2. The first one, this is a burst with the rhythmic, potentially ictal appearing pattern. And the second one is we are seeing polyspikes here. So, and these are the spikes which are rhythmic. And if this is happening in more than 50% of the bursts, they will be categorized as highly epileptiform bursts. So again, while describing your bursts, you say that if they're highly epileptic or not. This is an epoch which shows burst suppression with highly epileptiform bursts. So all these blue arrows on the top, it shows the epileptiform discharges. For this particular epoch, they are showing only one epoch of burst suppression, right? And there are about 6 of them, yes, 6 discharges. So, and these are more than 1 hertz. So these are highly epileptiform bursts. Okay, the confusion is still not done yet. We have something called identical bursts. Burst suppression with identical bursts. This pattern is usually seen in patients after cardiac arrest. So cerebral ischemia due to cardiac arrest, it causes identical bursts. So why the bursts are considered identical? The first 500 millisecond. That means if you are looking at the burst, the first half a second of each burst. Don't think about the voltage, don't think about the duration. So if the first half a second of each burst resemble, they are categorized as identical bursts. Okay. So this consists of frequencies from beta to delta band, and there is no clear dominant frequency. So we are calling them mixed frequencies there. They occur 1 to 2 days after cardiac arrest, and they can continue for up to days. So these identical bursts, they are sign of poor outcome in comatose patients after cardiac arrest. In one of the study, about 20 patients who had identical bursts, they had poor outcome. And 10 patients without identical bursts, so the study by Hofmeier et al. In 2014 published a data which shows that all those 20 patients with identical bursts, they had poor outcome. However, 10 patients without identical bursts, they regained consciousness. And patients with identical bursts, they did not regain consciousness. So what's happening here? Why it is happening, right? So we know cardiac arrest causes cerebral ischemia, and which leads to disturbance in the synapses. And that causes irreversible damage. So that's the reason we are seeing those identical bursts. So basically all neurons are producing similar action potential, similar cortical activity, which leads to identical bursts. Let's look at the ACNS guidelines. So if you look at the morphology of the burst and the duration of these bursts, it doesn't match, right? It's quite dissimilar, all 3 bursts. But the first half second of these 3 bursts is identical. So the identical bursts are present in half a second, first half second of your burst, okay? It is visually similar in majority of the bursts. So almost 90% of the bursts look like this. And if you recollect, or if you are ever hooking up a patient with cardiac arrest, just look at their bursts. Most of their bursts are identical. Here is another example, a stereotyped cluster. Okay, this is again cardiac arrest patient. I know it's a little confusing between this and this. So these are identical bursts. So a stereotyped cluster of bursts, of a burst suppression pattern. So here you have 2 or more bursts in a stereotyped cluster. Their first half a second is identical. So we are putting them as identical bursts. Now let's club together highly epileptiform identical bursts. This is burst suppression pattern in a patient with cardiac arrest. So we have a very clear burst suppression, 2 seconds of burst and about 5 seconds of suppression in between. In here, first half a second, if you look clearly, the first half a second of the burst is very much identical. Look at the second half of the second. In the first burst, it looks like very rhythmic sharps, but here there are spike and wave. So the next half is not identical. And they are highly epileptiform because they are longer than half a second. They have more than 2 epileptiform discharges. So this is a beautiful example of identical, highly epileptiform bursts. I know EEG has not changed. EEG is what it was since it's the first time it was recorded. But here we are naming it, describing it differently. This one here is non-highly epileptic burst. Don't get confused. Don't take it that it is something wrong. These are epileptic, but they are not highly epileptic bursts. For a burst to be highly epileptic, we want 2 discharges, right, in one burst. Here, if you see, the bursts are longer than half a second, which makes it a burst and not a discharge. And there is only one epileptiform discharge here in this burst. And what's the other one? And their frequency, they are not occurring greater than 1 hertz. They are less than 1 hertz. So this particular pattern is described as identical, non-highly epileptiform burst. Identical because the first half of each burst is identical. It looks similar. All right, enough with EEG and the burst suppression patterns. Let's talk a little bit literature here. So what's the difference? Medically induced and pathological burst suppression. It is burst suppression. EEG is showing burst suppression. And just now we looked at different types of bursts, different morphology, right? Maybe their location is different. So the burst suppression which is induced using general anesthesia or any other sedative agents, those bursts are heterogeneous. They appear and they disappear gradually. However, because of the cardiac arrest or any other conditions, when you see burst suppression, the bursts are identical. And they are characterized by abrupt transition from burst to suppression. So you're not getting, of course, now you know the duration, right? You know that there is 5 to 7 seconds of suppression and the burst will appear. But there is no kind of a message coming that burst is going to come other than the duration. So there is an abrupt transition, the burst appears, and abruptly the suppression will appear. There is no gradual change happening, right? And pathologically, between cardiac arrest and status epilepticus, right? And EIE babies. So these bursts, they look different. The burst suppression pattern is different. The ratios is different. Morphology is different. Maybe localization is different. Coma in general causes burst suppression, right? These two terms, like if you hook up a comatose patient, you're going to see discontinuous EEG, you're going to see maybe burst suppression EEG. So what's happening during coma? The brain gets inactive. Patient is obtunded. Patient is not himself, right? There could be some structural impairments. Maybe the functions of the neurons is not there. Patient had stroke, lesions, maybe some toxic and metabolic reasons, some trauma to the brain, hypoxic ischemic injury after cardiac arrest. So all those conditions can cause inactivity of the brain, of the neurons, and can lead to burst suppression. So we know comatose patients are non-reactive to a stimuli. Even their EEGs don't change much, or they may be very mildly reactive. So the burst suppression during comatose state, it kind of goes hand in hand. They are pretty close to each other. They are pretty similar, right? One is a clinical condition, another is an electrographic condition. It reflects that inactive brain, basically, right? And as the patient's coma gets deeper and deeper, the suppression increases and the bursts decrease. So that means your burst suppression ratio is changing, the percentage is changing. You're getting more and more suppression as the coma deepens. What about cardiac arrest? The burst suppression and cardiac arrest. So We know that with cardiac arrest, there is low oxygen to the brain too, right? Immediately after cardiac arrest, the patterns will look suppressed. A brain which is not significantly affected due to cardiac arrest, due to that anoxia, due to the ischemia, it will start to recover. And gradually you will be seeing changes in the EEG pattern, right? From burst suppression, it may become discontinuous to near continuous, and then maybe continuous. There will be increase in the frequency, increase in the amplitude of the background. But if the injury is severe, the hypoxic ischemic injury due to cardiac arrest, if it is severe, it's going to lead to synaptic failure. And the first thing that gets affected is excitatory synapses. That means you are seeing suppression. There is no excitation happening of the neurons. So the cortical activity will decrease. That's when we are seeing more and more suppression. And because of anoxia, ischemia, the energy levels are decreasing. The sodium-potassium pumps will be non-functional, and the neurons will get completely depolarized. So they're not producing any activity, right? Which leads to burst suppression pattern gradually. And the burst suppression pattern in cardiac arrest patient without any sedation, the prognosis is poor, right? And in cardiac arrest, over 90% of the patients will have burst suppression with identical bursts, and those identical bursts have voltage up to 128 microvolts. They are bilateral synchronous and they are high voltage. So they are sharp spikes. And that is another indicator of poor prognosis in these patients. So here is an example. These are highly epileptic identical bursts in a patient with cardiopulmonary arrest. And he's having myoclonus too. Status epilepticus, bread and butter of our life, right? So status epilepticus, we all know it's a life-threatening situation. And the continuous seizures can increase the morbidity, mortality rate in patients. And if status epilepticus is not controlled, it can transform into refractory status epilepticus. And like all those meds, the benzos, the barbiturates, and phenytoin, when they don't work on a patient who is in status epilepticus, it means the patient is going into refractory status epilepticus. So while reading some articles to put this presentation together, one statement came multiple times. Stopping of seizures is the holy grail, but most people accept a burst suppression pattern. I mean, it's a beautiful story told just in one sentence, right? Of course, we want to stop, the patient should stop seizing, right? If the seizures are not stopped, so we kind of come to a middle ground that, okay, let's have a burst suppression in these patients and gradually let the neurons come back to their baseline, let the brain heal, let the metabolic demand change over a period of time. So burst suppression is sort of a very friendly gesture, considered a very friendly gesture in patient with status epilepticus. So to treat status epilepticus, burst suppression is induced. So we have this hyperexcitable brain. The neurons are continuously firing, right? And persistent state of hyperexcitability, it's going to cause permanent damage to the neuron, right? And these neurons need to stop being hyperexcited. That's when the sedation is introduced. And this sedation is to provide physiological stability. Right now, the brain has gone haywire. The neurons, the metabolites, the toxins that are accumulating, all the ions and the electrolytes in the brain, they are getting overused or maybe accumulating. So we need to provide homeostasis. We need to provide physiological stability in a seizing brain. a continuously seizing brain. So what is given is sedation, and it is titrated, maybe one, maybe two combinations to achieve burst suppression. So, of course, like I read that statement, right? We want the patient to stop seizing. So to control seizures, it is going to be a gradual process. Let's suppress the brain. Let's produce a pattern of burst suppression. And let's control the duration of the burst by titrating the sedation, and gradually the brain will stop seizing. So when the patient is put on induced burst suppression in status epilepticus, we see that the clinical component of the seizures, it stops, right? There may be some subtle signs. Patient who has generalized tonic-clonic will be having some sort of twitching and tremors around the mouth, or maybe hand is twitching or leg is twitching, but at least because of the sedation and whatnot, and the brain is sort of stopped from overreacting and overexcited, there will be some subtle symptoms. The next thing is electrographic seizures, controlling the electrographic seizures. They will continue. Your bursts will tell the story that the neurons are still hyperexcitable, and the suppression is telling that, okay, the synaptic activity is slowed down or is being stopped. So in this condition, the decisive factor is the duration of the suppression, the percentage of the suppression. So this suppression is titrated, very carefully monitored. The patients are hooked up to EEG, so we are kind of reporting every hour or 30 minutes or 2 hours what is the percentage of suppression. Okay, so the aim is, like I talked before, is to suppress the seizure activity, right? And achieve a burst suppression typically for 24 hours. Many labs that I have come across, their target is like they will keep the patient on those sedation agents for 24 hours, and then they start to wean the patient off. If the patients start to have seizures again, they will put the patient back on again for 24 hours. The target is 80% is a magic number, but if the patient is still having identical highly epileptiform bursts, the suppression target can become close to 100%. They're going to completely suppress the brain. So in one of the study by Rosati et al., so it says that patient who had refractory status epilepticus, 31% of, so they conducted a study on 128 patients. The data they used was from 127, but 28 patients. So 31% of patients with refractory status epilepticus came back to baseline. But 50% of non-refractory status epilepticus patients came back to baseline with induced burst suppression. So it's not a great number, but at least there is success for patient to stop seizing and come back to baseline. Let's talk a little bit about interoperative, general anesthesia and burst suppression. So during the surgery, during cardiac and non-cardiac surgeries like aneurysm or carotid endarterectomy, intracranial hypertension, these patients, when they undergo surgery, the suppression of metabolic activity of the neurons is considered neuroprotective. So how can you decrease the metabolic demand of the neurons? By decreasing the cerebral blood flow and decreasing the cerebral metabolic rate of oxygen consumption. By these two mechanisms, the activity in the brain can be decreased or quote unquote suppressed to provide cerebral protection during the surgery. So during the surgery, of course, we know that there is cerebral ischemia. So when the demand is less, the cerebral ischemia will not be felt as much. So again, it is providing neuroprotection in an OR setting. But we are seeing many patients, especially elderly patients, who undergo surgery. They have change in their background. Post-operatively, they have change in their baseline attention, their awareness, even their cognitive abilities. It is an acute change, and it may or may not last forever, but it is a serious complication, patients coming out of surgery, and happens in 50% of older patients. There is delirium in ICU, but it is not post-operative delirium. That's altogether a different story. So I think before they used to use the term ICU psychosis, which is not being used anymore, but there is ICU delirium. It is a lot different, I should say, than the post-operative delirium. So we'll focus on POD here. So this POD results in longer hospital stays. And the patient's medical bill can go as high as $60,000 more than what they were supposed to pay, because long hospital stay, their therapy and other stuff happening, right? So this is reported in 2015 by American Geriatric Society. So what role does burst suppression play in POD? So the excessive anesthesia, or how the neurons metabolite the sedation during surgery, it causes post-operative delirium. And if a patient during surgery is having EEG guided and depth of anesthesia, the risk of POD can be significantly reduced. So the burst suppression pattern that we see in elderly patients during surgery, they can be used as prognostic factors. There is no statistical significance that they are going to predict if the patient is going to have POD or not, but they can be used as prognostic factors in them. And it is completely an independent risk factors. There are studies, they are in for it, they're against it. It's still a very confusing topic. So they always talk about what is it causing? It's the age of the patient, underlying condition of the patient. The longer the suppression, again, the studies are not talking about, okay, this percentage of burst suppression is okay. This percentage will not cause POD. So there is no clear kind of criteria there, okay? So longer duration of EEG suppression with decrease in faster frequencies leads to risk for POD. That is a review article in 2023. So definitely longer suppression. And if a patient coming out of anesthesia is still showing delta theta activity, loss of faster frequencies, not gaining the theta alpha background, it is definitely an indicator for POD. So what message are we taking? Now we saw that burst suppression works in our favor, like status epilepticus, right? For brain to heal, brain to come back to baseline. We saw almost 50% of the patients, they came back to baseline with induced burst suppression. But at the same time, burst suppression in the OR setting with general anesthesia is not working in patients' favor, especially when they are elderly. So some worth considering is, how about doing EEG during the surgery? No matter what the surgery is, the depth of anesthesia can be evaluated based on the EEG frequencies, EEG background, the voltage, right? The amplitude of the frequencies. And the anesthesiologists, they can use EEG as one of the monitor in the OR. And another thing that some of the review articles talk about is the post-operative delirium, is it because of the excessive anesthetic dose given to these patients? Or is it their brain is already vulnerable? So it's a vulnerable brain that is producing POD, or is it the excessive anesthetic dose that is exposing the brain to postoperative delirium? So what is the normal anesthetic level? Again, the depth of anesthesia can be measured with the EEG background. And we have seen that it's not all working against our favor, the burst suppression, because we have seen refractory status epilepticus and status epilepticus. If they are not controlled, if the burst suppression is not induced, it can lead to morbidity and mortality. So burst suppression, according to me, as long as I know my enemy, I can be friends with them, right? So that's what I thought about. Know thy enemy. All right, so that's all I have. If there are any questions, please feel free to put them in chat.
There are a couple in there, one from Jean and one from Pat. So Jean is asking, what is the age range for POD?
It's 60 plus patients who have, so patients above 60 have 50% chance of having POD.
And then from Pat, he says, in fluctuating burst suppression, if I'm using a 10-second sweep of the variability of the burst suppression duration and the interburst intervals are variable between 10-second sweeps, a range statement referring to multiple 10-second sweeps may be useful, or can I use a 30-second sweep to count the number of IBIs to state the percentage of suppression per minute?
So you can use 2 minutes of epoch. So if you have 10-second epochs, just see what your frequency range is, what your percentage of suppression is or duration of your burst is in 2 minutes. So like in the very beginning, we were talking about different categories of burst suppression. So they take 2 minutes epoch and see that like how much of suppression is happening. So if you have variable duration of burst, if you have variable duration of suppression, take 2 minute epoch and get your numbers. And you can always describe your burst suppression your suppression percentage as a range, if not an absolute number. Any other questions? Yes, Jean, there are CEUs. You will be getting an email like what Brad mentioned earlier. You will get a feedback form. You fill it and send it back to us. Then we will send it to ASET. Thanks, everyone.
There is one more question.
Okay. Yep.
What is the suppression duration to prevent POD?
Okay, so it is variable. There is no fixed number that they are talking about. They are saying that the burst suppression is not an indicator, but it can be used as prognostic factor. And when the patient is recovering from anesthesia, you can see what the background frequencies are. So that's why the suggestion that during a surgery, if a patient is on a real-time EEG monitoring and loss of faster frequencies is for longer periods of time, that can be an indicator for POD. So the depth of anesthesia can be controlled so that the patient does not lose faster frequencies. Like from alpha, they are not staying in delta throughout the surgery. Jean, I'm not sure if people are using EEG in the OR. I think if anybody here in interoperative monitoring can answer that question, that will be great. I don't think it's used for every surgery, but definitely any surgeries related to brain or carotids, the intracranial hypertension. I'm sure they're using EEG, but not for other surgeries, non-cardiac surgeries. I agree, Jean. Have a good night, everyone. Look for the next webinar in December. I don't know if Tanya is still here. Tanya had a question. What is recommended criteria for burst suppression for neural protection? The recommended and the required is 80% suppression. But if the electrographic seizures are not controlled, it's going to be 100% suppression. Thanks, Tanya. So Tanya says that they use EEG to help describe changes in SEP and MEP data in terms to depth of anesthesia, decreased excitability. Good to know. Thank you. So Deandra says they run 3-channel EEGs to detect burst suppression during spine cases. Thank you. All right. Good night, everyone. See you next time.